Good morning, everyone. Today, the topic of my lecture is cross-sectional imaging of the normal eye. So, first of all, we will begin with the ultrasound imaging of the normal eye. So, beginning from anterior to posterior. So, first, we are able to see the cornea, which appears as a thin echogenic membrane, and then posterior to it is the anterior chamber. Then we can see the echogenic bands which extend from the eye, and this is the iris, and in the center is the pupil. Now, posteriorly, we can see the lens, the choroidal body, and then behind this is the vitreous chamber. Now, the thick echogenic outer membrane, which consists of the retina, choroid, and the sclera, is seen. These layers cannot be differentiated on the ultrasound, and this is known as the uvea. Now, posterior to the eye globe, we can see the hypoechoic structure, which is the optic disc and the optic nerve, and this is embedded in the echogenic retroburbar fat. Now we proceed to the extraocular muscles. The normal extraocular muscles, they are seen as the hypoechoic band, and the medial and the lateral rector muscles, they are seen on the nasal and the temporal sides, and the maximum normal thickness is 3 millimeters. Now we are done with the ultrasound. Now we'll proceed with the CT anatomy. So first we go through the axial CT anatomy. So these are the normal axial CT scans inferiorly to superiorly. So inferior axial CT scan, in the first image, we can see the maxillary sinus, the nasolacrimal duct, and the inferior orbital fissure, and some part of the inferior rectus. In the mid-axial CT scan, we can see the entire optic nerve sheath complex, and it is entering into the optic canal. And lateral to the optic foramen is the superior orbital fissure. We can also see the sphenoid sinus, the medial rectus, the lateral rectus, and the globe. And the axial CT scan to the superior orbit would show the superior ophthalmic vein, the superior rectus muscle, the superior oblique tendon medially, and the lacrimal gland laterally. Now we are coming to the corneal CT anatomy, anterior to posterior. So these are the sections at the level of the equator of the globe. In this, we can see the lateral rectus, the superior rectus, the medial rectus, the superior oblique. This is the levator palpebrae superioris, the lacrimal gland, and the inferior oblique muscle. Now, when we go posterior to the equator, then we can see the medial rectus, the superior oblique, the ophthalmic artery, the levator palpebrae superioris and superior rectus complex. We can see the dural sheath, the superior ophthalmic vein, the subarachnoid space, the optic nerve sheath complex, the lateral rectus, and the inferior rectus. In CT, we have the bone window and the soft tissue window. Now we'll proceed to the axial bone window. So this will show the anatomy of the bony orbit inferiorly to superiorly. So what we can see inferiorly, we can see the nasal bone, the maxillary bone, the zygomatic bone, the inferior orbital fissure, foramen rotundum, pterygopalatine fossa, maxillary bone and sinus, the lacrimal bone, and the nasolacrimal duct. When we move superiorly, we see the nasomaxillary suture, lacrimal bone, greater wing of sphenoid, superior orbital fissure, central sphenoid bone and sinus, sphenotemporal suture, sphenozygomatic suture, and the lamina praepatia. More superiorly, we can see the frontal recess, the ethmoid sinuses, the optic canal, stella turcica, the optic struts, superior orbital fissure, and the greater wing of sphenoid. Now, these are the corneal bone CT. We will see the anatomy of the bony orbit, posterior to interior. So, this is the section taken at the bony orbit at the orbital apex. So at the orbital apex, we can see the optic canal, the superior orbital fissure, foramen rotundum, sphenoid sinus and lateral recesses, the Vedian canal, optic strut, and the anterior glenoid process. So bony orbit at the mid-anterior level, we can see the frontal bone, the orbital process, the inferior orbital fissure, the lamina praepatia. And more anteriorly, we can see the frontal sinus, the nasolacrimal duct, and the infraorbital canal. Now before proceeding to the MR anatomy, we will just quickly go through the anatomy. So we all know that the extraocular muscle, they rise from the annulus of Zinn. So this diagram represents the same. So we have the levator pectoris superioris, superior rectus, the lateral rectus, inferior rectus, medial rectus, superior oblique, and the trochlea. And in the center is the ophthalmic artery and the optic nerve sheath complex. So these are the corneal T1 weighted MR images, and we are depicting the corneal MR anatomy posteriorly to anteriorly. So we can see the superior rectus muscle, the lateral rectus muscle, the inferior rectus, the medial rectus, and the superior oblique. And in the center is the optic nerve sheath complex. So coming anteriorly, again we can see the levator palpebrae superioris, superior rectus, and beneath is the superior ophthalmic vein. And then we can see the lateral rectus, inferior rectus, and inferior ophthalmic vein. And here we can see the medial rectus and superior oblique. And more anteriorly, we can see the lacrimal gland. And this is the globe. Now we will proceed with the oblique sagittal T1 weighted images. And in this oblique sagittal T1 weighted images, we can see the levator palpebrae superioris muscle. Posteriorly and anteriorly, we see the levator aponeurosis and the mular muscle, the orbital septum, the globe, the inferior oblique, the inferior rectus, and the optic nerve sheath complex. And in between the superior rectus and the optic nerve sheath complex, we can see the superior ophthalmic vein. These are the axial T1 weighted images. In these, we can see the lacrimal gland, the intraorbital part of the optic nerve, the ophthalmic artery and its branches, the optic nerve in its intraclavicular part, and the optic strut. So optic nerve sheath complex, what is it is made up of? It is made up of optic nerve, perioptic CSF, and the optic sheath. So the coronal and the STIR MR images, they can very well depict the optic nerve sheath complex. So in this, we can see the optic nerve in the center and perioptic CSF sheath around it. And this is the infraorbital nerve, superior rectus. So again, the axial STIR MR images, we can see the anterior segment of the eye, the lens, the vitreous chamber, the medial and the lateral rectus muscles, the intraorbital part of the optic nerve, in which we can see the optic nerve, the perioptic fluid, CSF, the optic nerve in the interclanicular part, intracranial part of the optic nerve, optic chiasma, and the optic tract. Now the last is the globe. So what are all structures we can see with the globe in the MR? So outer coat layers, we see the sclera, the choroid, and the retina. Then we can see the optic nerve, the vitreous. Anteriorly, we can see the cornea. We can see the anterior chamber, the lens, the iris, and the ciliary body. Thank you.
Yeah, thank you, Dr. Harkirat. I think if there is any questions, we can do during the tea session. And next, we have Dr. Richa. She is from the Department of Anesthesia. She is going to teach us about basics of CPR. And CPR, mind you, it's a very important subject. You may end up patient trouble during the surgery or even in the emergency and all. So learning of CPR is very, very important for every person. So she is going to give us basic tips how to manage a patient where you need to do a CPR.
So, good morning, everyone. Thank you, sir, for the kind introduction. And at the outset, I'd like to thank the Department of Ophthalmology, Suresh, sir, my dear friend, Dr. Parul, sitting here, and the entire organizing team for giving me an opportunity to talk about this. So, when we talk about CPR, it is something which is not in the preview of, today what you are discussing about ophthalmology. It's primarily ophthalmology, this thing. So before we start, I'd like to ask someone from the house who has ever done a hand-on rescue at home or outside. Anyone? Sir, I would like to share his experience. Yes, sir.
Once I was traveling somewhere in Mathura, so suddenly there was 40 people, they were traveling, and suddenly one middle-aged person, 50-60-year-old, I think, he suddenly collapsed. So we were also just in that area. So immediately I was not knowing initially what to do, but whatever I learned during my MBBS career, so I went there and immediately I started doing with the initially I tried for mouth to mouth a little bit, then with the hand I tried to do, but I tried for 50 minutes, but unfortunately he didn't survive. So then I tried to arrange intracardiac adrenaline, but that they could not arrange at that place, so patient could not survive and refer to nearest place. But I
think
tried my
sir
best.
deserves a big applause. Why? Because he has completed the entire lecture in one sentence. So what I want to emphasize here is that when we talk about CPR, what is CPR? It is an attempt to restore the spontaneous circulation which has stopped because of whatever reasons, with a broad range of maneuvers and techniques without using any, much of the equipment. And the goal is to provide oxygenated blood and to maintain perfusion to the vital organs, right? So is there need for all of us to learn about it? Yes, there's definitely a need. Approximately there are around 700,000, 7 lakh cardiac arrests per year, and the survival to hospital discharge is only 5 to 10%. While the intra-hospital cardiac arrest, they have a better prognosis. The out of the hospital cardiac arrest, they still have very grim prognosis, and that is why early resuscitation and prompt defibrillation can result in more than 60% of the survival. Fortunately, I can actually tell that whenever you learn CPR, and if you provide it nicely at home, outside the hospital, you can actually save a life. And believe me, we are all healthcare provider. We should all know it, how to do it. So any attempt at resuscitation is better than no attempt at all. We have to remember. And the best chance of neurologically intact survival depends upon whether the victim's collapse was witnessed, whether CPR was commenced immediately, the cardiac rhythm, we'll not discuss it, whether defibrillation was performed or not. And when we talk about CPR, there's something known as adult chain of out of the hospital, cardiac arrest survival. If you see here, the compression take a very early, place here. So good compressions is the key to save one life, believe me. So if you see here, all the, whatever we talk about, cardiopulmonary resuscitation, it is guided by the American Heart Association algorithm, and you can all download it, the basic life support algorithm from the AHA site. You can keep it in your mobiles, and if you always think that, I'm not remember what is to be done next, you can always take a guide. So whenever you're performing, always ensure, if you see a collapsed victim, always ensure that the scene is safe. That means, that the scene is saved both for the rescuer and for the victim. I'll just like to quote an example. When I was doing my senior residency in MAMC, there were 2 technician brothers who used to work with us. There was a fire in the OT, and one of the brothers, he was stuck in a room. So the other technician brother also, went into that room. Unfortunately, we lost both of them. So, do not risk your own life. Wait for fire brigade to come. Ensure that the scene is safe. After you have ensured, and there's a person who has collapsed, after you've ensured, you take always universal precaution, whatever is available for you. And then always check the responsiveness for 5 to 10 seconds. Always face the victim, tap and shout, and ask whether he's okay or not. And if there is no answer, please activate the emergency medical services. The emergency medical services in India is 112, and I think we should all know about it. We all know in Punjab we have 108. If you're not able to get through the emergency services, national emergency services, you can always call 100, you can call 101, right? But you should know these phone numbers. These are handy. Someone will come. We are proud to share that all the PCR vans in Chandigarh, they are all BLS trained. They have defibrillators. So if you will call even at 100, they will provide some kind of basic life support to the victim. So if no one responds, activate EMS, start CPR, but before starting CPR, do a pulse check. How do you do a pulse check? It is carotid pulse in adults, right, in brachial in infants. How do you count 10 seconds in case you are alone? You count, chant 1001, 1002, 1003, up to at least 1008 before declaring that the patient is not having pulse, and then resume the chest compression. Start the chest compression. Always know that the victim should be placed on a firm, flat surface. Kneel beside the victim, expose the chest. Expose the chest if you think it's a male. If you think it's a female, you don't want to expose, you can do that, by feeling the landmarks, anatomical landmarks. Place hands on the lower half of the breastbone, heel on one hand, heel on the other, something like this. And place the heel on the hand of the sternum. Interlace the fingers to keep them off the victim's chest, and then start compressions to at least 5 centimeters, but not more than 6 centimeters, and the compression rate around 100 to 20 compressions per minute. There are certain attributes to a good compression. Always push hard and push fast, right? Chant loudly, because if there's no one with you, you are the lone person, you should know that, how many compressions have gone by. Allow complete chest recoil between the compression and minimize interruptions less than 10 seconds. I told you how to count the seconds in your mind about, how to check the time. And this is how you give, wait a minute. Always see that the hip of the rescuer should always be above the level of the victim, right? If the level of the hip is at the level of the victim, that means you're not providing right compressions. You just see, and these three, joints, the shoulder joint, I actually want you to see it, because this shoulder joint, this elbow and the wrist, they should be in a perpendicular manner, right? And then you should be using your hip joint to deliver the compressions to the victim. And this is how the CPR is done. Clear? So along with that, I want to emphasize here is that along with that, one is that you're giving only compression only CPR. The compression only CPR is where you do not want to give breaths to a patient, right? So you're only providing compressions to the patient. How many compressions? 100 to 120 per minute. So at least 2 minutes के बाद आपने check करना है कि दोबारा उसकी pulse है कि नहीं है, after 2 minutes, right? But believe me, we are all healthcare providers. We should know how to give rescue breaths. So I will not go into the detail, but you can open the airway with a simple maneuver of a head tilt and chin lift, right? And even if there's a doubtful cervical spine injury, the airway always takes the priority, right? And you can give breaths to mouth to mask, and a bag mask. Mouth to mouth, usually nobody likes to give mouth to mouth breathing these days, so we use a mouth to mask. It's a one-way valve. It's very easily available. 350 rupees for a mask. Everybody can carry it in their bags. And believe me, I have saved at least 4 lives on the roadside by using this mask on victims, right? And then you can use this mouth to mask technique like this. And last but not the least, I would say that you should know what is an AED. AED stands for an automated external defibrillator. Whenever you ask the EMS services to, you call up 112, you should always ask them to bring a defibrillator. Why? Because 80% of the adult cardiac arrest, they are because of ventricular fibrillation, which is a shockable rhythm. So if you don't shock it, you don't defibrillate them, they will not survive. The chances of survival, they remain grim. And that is why you should always know what is an AED. And it's a very simple device. It's a very, very simple device. It follows visual and voice prompts. So you don't have to do anything. You just have to remember one thing. This is something, they are available in many kinds. So you can find them at airports, railway stations, school, shop. Please, whenever you go to a mall next time, please take out 2 minutes and see where the defibrillator is. If you go to a railway station, please see where a defibrillator is. You will actually find the government of India has done a great job putting up AEDs everywhere, all over the public places, right? And you don't have to do anything, you just have to follow voice prompts, and you can just use a mnemonic that is PASS. Power on, just attach the pads, analyze rhythm, it is going to shock itself if it's a shockable rhythm. And if you see here, the number of makes of AED, but don't worry, if you just remember this PASS, you'll be able to save a person. After, you have given a shock, just start the CPR again. And believe me, one life saved can actually matter a lot to a family, to the society. And more important is that, say you are alone, when to terminate BLS. Like Sir appropriately pointed out that he gave CPR for 15 minutes, but he was unfortunately able to revive the patient. So it is important to know that when to stop it also. So if the arrest was not witnessed by an emergency medical services personnel, right, there is no return of spontaneous circulation before transport, and no AED shock has been delivered before the transport, you may, stop the resuscitation. But believe me, when we talk about resuscitation, stopping the resuscitation, it actually depends upon so many factors. If there's a near and dear one, I would like to continue for 45 minutes. If there's a near and dear one, I'll actually emphasize to please take the patient to the hospital and do whatever you can, right? So it is I think the idea of providing compressions, it has to start from us. It has to start from that we can do it, we have to do it, we have to save a patient. So it is for all the healthcare providers to learn it. The basic skill has to be learned, it has to be ingrained, and basically any CPR, any day is better than no CPR. Early initiation of EMS, you all know which number to call up? Which number to call up? 112, and any CPR, even by a layperson, can actually save one life. And we are all healthcare providers. We all are healthcare providers. We should know how to give adequate compression with minimal pauses and airway breathing. And we should also know that we have to defibrillate early, right? So thank you very much. Let's save life together. Thank you.